Good morning, Dr Cary.
Good morning, sir.
Miss Graham, Senior Counsel to the inquiry, will take your evidence. Before that, would you say the words of the affirmation after me, please? I solemnly, sincerely and truly
I solemnly, sincerely and truly
declare and affirm
that
I will tell the truth,
I will tell the truth,
the whole truth,
and
nothing but the
and
truth.
nothing but the truth.
Miss Graham.
Thank you very much. Good morning, Dr Cary.
Good morning.
You're Nathaniel Cary.
Yes,
We've heard some people call you Nat.
yes. I'm more than happy with that.
Yeah, I won't be calling you Nat today.
Okay,
But if we've heard evidence of a Nat, that's you.
it is.
We have your professional address and contact details, so there's no need for you to give those today.
Thank you.
I'm correct in saying you're a consultant forensic pathologist?
That's correct.
And I'm going to deal with your experience and your qualifications in a moment. I'd like to go through those with you.
Thank you.
But can we look first of all just at a couple of statements that you've given to the inquiry?
Yes.
The first statement was taken from you on the 17th of November 2022.
Yes.
And if we can have that up on the screen. Now, while you look at that, you'll see that this document is appearing on the screen, and we can work through that today and we can look at that, any documents on the screen. In addition, there's a blue folder in front of you, and that contains hard copies of the documents we think you may want to have regard to today.
Thank you.
Now, you must feel free to use any of the hard copies that you wish, or if I am referring to something, it might be on the screen. But if you think there's something else that we should have on the screen, please let me know.
Thank you.
And we'll make sure that's up there. If we can also look at, I'll come back to the statement in a moment, but if we could look at your CV, you've provided us with a brief CV, WIT 00037. And we'll see that this says brief curriculum vitae for yourself, and you're a Home Office registered consultant forensic pathologist.
Yes.
Are there many Home Office registered consultant forensic pathologists?
The list is usually about 35 to 40, but that's for England and Wales, and of course there are equivalent forensic pathologists in Scotland and in Northern Ireland.
What sort of cases do Home Office appointed pathologists do?
Primarily what would be called suspicious deaths, and so those are cases where there may be some form of third-party involvement. That could be direct third-party involvement, or we get involved in things like manslaughters, involuntary manslaughter, all that sort of thing. So there's a wide range of casework to cover.
Were you involved in the Litvinenko case?
Yes, I was, which was obviously a fairly unusual kind of a case.
And am I correct in saying you had to carry out your post-mortem in a big white suit?
Yes, we had full
to protect
protective
you?
clothing, including ventilated hoods.
So you had to be protected from radiation?
Yes, and we had
yourself?
a radiation protection officer with us at all times to make sure the levels never went up to anything unacceptable.
And am I also right in thinking you've also been involved in a number of high-profile cases, including the Soham murders?
I have, but it happens to be that I was just the person on call at the time, so I don't particularly seek out such cases, they just happen.
Right. And am I right in thinking you've also been involved in the Hillsborough disaster?
Yes, so the re-inquiry into that a few years ago now.
Where people suffered crushing injuries and...
Yeah, they had
That's
crush
what-
asphyxia in a crowd, and in fact we published a paper after that which showed the range of what you might see after a crush experience.
Thank you. Tell us about the work that you do as a forensic pathologist, about the experience you have.
So much of the work would involve carrying out a post-mortem examination and then commissioning further tests. That's not always the case, but there might be no post-mortem examination, there might be no body, So we may simply give expert opinions as forensic pathologists in a whole variety of circumstances, but most of it would involve carrying out a post-mortem examination.
So you're doing the post-mortems yourself?
Yes, exactly.
And do you do what we've heard referred to as a double doctor post-mortem? I think the position in England is slightly different.
It is, although I introduced that in relation to paediatric cases in England some years ago now, because I think the range of complexity in a paediatric case with natural disease as well as an important factor, especially in babies. I felt and others felt that it would be worthwhile to have a paediatric pathologist there as well. So I am familiar with having a double doctor system, which in my opinion is a very good system. Maybe we should think about it in England.
And that's something you helped to introduce in England?
For paediatric, yes.
Right. And paediatric being babies and children?
Babies and children.
And as well as that aspect of your work, do you also do a lot of medical legal reports and opinions?
I do, although probably less so now.
Can you help the chair understand the sort of number of reports that you've prepared, medical legal?
Yeah, of course. I mean, it runs into the hundreds. It's always easy to exaggerate, but it probably runs into the hundreds. And then, of course, there'll be the full post-mortem reports. And over the course of many years, I've carried out about 30 to 40 post-mortem examinations, and some years I've done more.
And how many years have you been working in this field of forensic pathology?
I've been on the Home Office list since 1992.
And prior to that, were you also working in this
Prior to that,
field?
I was working, and I continued to work for some years as a consultant pathologist, carrying out diagnostic pathology. My role was particularly as a specialist heart pathologist, and that's when I worked at Papworth Hospital in Cambridgeshire, and I had responsibilities for transplant pathology and other aspects of heart and lung pathology.
And all of this work has overlapped throughout your career?
Exactly. But now I'm not involved in transplant pathology anymore.
And what experience do you have of handling post-mortems involving or suspicious deaths involving deaths arising out of restraint?
A lot, I would say. I've had a particular interest in that really throughout my career. And so in a whole variety of circumstances, I've been referred cases, often as a sort of second or even third pathologist.
And what sparked that particular interest?
I've always been interested in the interplay between physiology, so how the body systems work and how they go wrong when something goes wrong, like death during restraint, and what might be the possible causes of that.
And when did your interest in this actually start? When was it sparked?
Probably from the very outset of my time working as a Home Office pathologist, if not shortly before.
So early 90s?
Yes, exactly.
Were you involved in a case involving Dennis Stevens, who died in Dartmoor?
Yes, I was.
Can you tell us a little about that case?
Yes, so that involved restraint. It also involved him being left on a hard floor, face down, for a very long time. And he suffered from sickle cell disease, I think, or sickle cell trait. I cannot remember which he had. But anyway, his death was characterized by a lot of sickling, which is blockage of little blood vessels really throughout the body by the red blood cells, which should normally be round, but they become long, sort of boat-shaped, and that then leads to them blocking up little blood vessels.
And was that something that could be seen on, pathologically?
Yes, indeed.
We heard yesterday from a Professor Lucas who talked about small blood vessels, particularly those into the lungs, can get blocked through the sickle cell. Is that the type of thing you're talking about?
Absolutely, yes. And there are other major organs where it's really very damaging to have small blood vessels blocked.
Thank you.
But I have worked with him over many years, including on sickling cases.
Thank you. That's Professor Lucas.
Professor Lucas.
And can I ask, have you given evidence before in courts or inquiries?
Many times, yes. In a whole variety of circumstances. I've actually given evidence in Scotland before,
Right.
in
Was that
fatal
in-
accident inquiries.
Right. Was that involving deaths?
Yes.
And could you tell us, you've told us about your Home Office work, are you predominantly instructed by prosecutors or defence?
Sometimes defence, sometimes just interested persons of one sort or another.
Right.
So I get a whole range of practice.
And do you become involved as an expert in civil cases as well?
Yes, on occasion. And the family, because I do quite a lot of paediatric forensic pathology, I'm involved in the family court quite a lot.
Right. So not just criminal, but civil matters as
A
well?
whole range of things. You always have to keep in the back of your mind different burdens of proof in the different circumstances.
Now, I think in terms of your involvement in relation to the death of Mr. Bio, just to be clear, you didn't carry out a post-mortem
No, I
on
didn't.
Mr. Bio, and you weren't present at the post-mortem carried out by Dr. Shearer
No, I
and
wasn't.
Dr.
Although I
Review.
do know them both, and I would be confident they'd be very careful pathologists in terms of evidence of fact collection, which is the first stage really. Opinion comes later, but the facts need to be collected in any suspicious death.
Thank you. And if we could look maybe at your letter of instruction, the 18th of May 2015, this is AAC 00377. I don't need to go through this in detail, but this was a letter of instruction to you, Dr Nat Cary, on the 18th of May 2015 from Amar Anwar and Company.
Yes, who sits behind you, I think.
He does, usually. And so this was a letter of instruction sent to you by Mr. Anwar, and you accepted that instruction. Can I ask you, what contact did you have with his firm round about this time, in addition to your letter of instruction?
I'm not sure if I did. I may have done though. If there's evidence I did, then I'll accept it.
I'm only asking the questions.
I think obviously the letter arose from a telephone call originally. I think Mr. Anwar rang me personally.
Right.
And so the letter follows on because in any circumstance I like to work to clear instructions so that we know where we're both coming from.
Mm-hmm. Did you have any meetings with the family themselves?
No.
Did you ultimately meet with the lawyers for the family from Mr. Anwar's firm?
I'm not sure. We may have spoken on the telephone. I don't remember a trip to Scotland though to meet.
Thank you. I just want to deal with this very quickly. There may be some people listening have concerns that you were instructed by Amar Anwar and consider that maybe this may have influenced you in some way when you were approached by them initially. Do you have any concerns yourself?
No,
about-
not at all. I mean, obviously in the course of my work, particularly getting involved in deaths in custody, if you are asked to act on behalf of a family, and fortunately there's increasing support for families in such circumstances, but I can tell you 10 or 20 years ago there's very little support. So you expect to be instructed by specialists in human rights really, and so that was not in any way a surprise.
And just to be clear, do you understand that your involvement with the inquiry, we wish you to help the chair primarily?
Yes, absolutely, I do understand that, which is, I mean, actually in any circumstance my overriding duty is always to a court, or of course sometimes there won't be a court appointed at the time, but it's to a potential court in the future, and I'm very mindful of that.
And do you bear in mind that it's important that you're independent and objective?
Yes.
And that you're not biased in favour of those who give you instructions?
No, not at all.
And do you take care to avoid that?
I do take care, and I think, it's very easy to fall into the trap of telling people what they want to hear, really. So I'm very mindful of that.
And do you
The
avoid
concept
doing that?
cognitive bias has been increasingly recognised recently in a whole range of forensic scientific and forensic pathological settings, that you might just say it's that because you're somehow involved in that whole area yourself. So I'm very mindful of that. The trouble is, with forensic pathology in particular, you have to know the history. It's no good trying to do it shut in a box, because if you don't know the history, you may not make correct decisions at all.
we heard evidence from Dr. Shearer at the beginning of this hearing, and she explained it was very important to consider the full background circumstances.
I agree.
Do you agree with that?
I agree.
Yeah. Thank you. Can we look now, please, at a report you prepared on the 23rd of October 2015, which is COPFS 00196. And you'll see your names at the top
Yes.
with your qualifications and titles. And then it says Statement of Witness. Now, as I understand it, this is effectively your report presented as a statement. And further down,
Yes.
if we carry down, it does say expert opinion, I think.
Yes.
On that page we've just passed, that contains your qualifications and experience.
Yes, exactly.
Which will enhance the brief CV we looked at a moment ago. And the chair can consider that later. And then if we carry on down the page, you then give a declaration understanding you owe an overriding duty to the court to provide independent assistance by way of unbiased opinion in relation to matters within your expertise.
Yes.
And such advice must be uninfluenced by the exigencies of the case, and you have complied with and will continue to comply with your duty to the court.
Yes.
And that would apply to the chair of this inquiry also.
Very much so, yes.
And then it is headed up expert opinion to Amar Anwar and Company Solicitors. And then if we move down, we then see that this is really where you go through your opinion on the matter, which has been based on a number of documents and information that's been sent to you by Mr. Amar Anwar's firm.
Yes.
Thank you. We will come back to your report in a moment. Let me turn first of all to your contact with this inquiry. I think you were contacted last year on behalf of the inquiry.
Yes, it was.
And you provided us with two statements. The first, SBPI 00268. This is your first statement, and it was taken on the 17th of November 2022. And if we look at the last page, it's 58 pages long, and we can see it was signed on the 23rd of February 2023.
Yes.
And I think, although our version on the screen is redacted, your hard copy will show your signature.
Yeah, thank
And
you.
it's on every page. I think you've docu-signed every page.
Yes, every page.
And the final paragraph, if we can see that on the screen, at 232 says, I believe the facts stated in this witness statement are true. I understand that this statement may form part of the evidence before the inquiry and be published on the inquiry's website.
Yes.
And did you understand that to be
I
the
did
case?
understand that, which is very sensible, being open and transparent.
Thank you. And then let's look at the second statement you've provided to the inquiry, which is 00269. And this was taken on the 17th of November also. And the last page, we'll see it was also signed on the 23rd of February 2023. And it's only 4 pages long. The final paragraph 15 is in the same terms as previously.
Yes.
And again, your signature on this document, which we can see at the bottom of the screen now, redacted, was given in the knowledge that this could again form part of the evidence available to the chair
Yes,
to
exactly.
consider.
So I was wondering originally if I'd be asked to get involved in these proceedings, because obviously I'd been involved at the beginning, and I was pleased when I was contacted, really, because I felt I had something to add.
Good. That's excellent. Can we turn back to your report then, and we can go through this and have a look. COPFS 00196. Let's go back to the documents you were sent. So this was following on with your letter of instruction. So this is the 18th of May 2015. It was at an early stage in the events, and you were sent a large number of documents to consider involving correspondence, a report and post-mortem report prepared by Professor Basutil. You had a copy of the post-mortem report from Dr Cary and Shearer and Dr Ralph Buhadir. You had the final post-mortem report, a neuropathology report by Dr. Smith, toxicology reports, and various other documents, radiology, photographs, stills, and information from the PERC.
Yes.
You were then also sent disclosure statements, you were sent civilian statements, and other statements that were copied to you.
Yes.
Since then, I think very recently, you've also had sight of GP and medical hospital records of Mr.
I have.
Bayu to consider.
Well, apparently GP records.
GP
I was
records.
aware, I think, from Dr. Buhader and Dr. Shearer's reports of some of the hospital records.
Thank you. Can we look at page 3 of 6 now, please, on your report? You say, this opinion will be in the form of a commentary on the final report of Dr. Shearer and Buhadir. And so, was this effectively what some may call a desktop report?
Yes, exactly.
Where you've looked at paperwork and you've then prepared your own views
Yes.
on the basis of that?
Yes.
And you
I also
give-
think, in my practice, I try and not use huge amounts of other people's work. My opinion is that the people need comment on that, really. It's much more helpful. Otherwise, you end up with a 50-page statement.
So the background, that was from information provided to you.
Yes.
And then you talk about external findings.
Yes.
And I think, is it correct to say that the information about the external findings would have come from Dr. Shearer's post-mortem report?
Yes, but I think I was able to confirm some from photographs.
So a combination of looking at the photographs and also considering the reports by Dr. Shearer.
Yeah, exactly, because you have to remember that the photographs are actually still original evidence. Providing there's a good chain of proof from the photographer, they actually count as original evidence, quite apart from what Dr. Shearer says descriptively.
So you're not just simply accepting what's written down in the report by Dr. Shearer.
Exactly right.
You're actually confirming by looking at the photographs
Yes.
what's said.
Yes, which is very important when you do a desktop exercise, that you want as much original evidence to review as possible.
And then if we can move down the page, please. You then talk about the internal findings. So that was during the post-mortem again. Did you have photographs of internal findings as well as what was written in the post-mortem report?
Yes.
So again, did you do a cross-check and consider the internal findings in light of those?
Yeah, I mean, fortunately, as I would expect from experienced forensic pathologists, there was good documentation in terms of photography along the way.
Thank you. And then if we can look at page 4. We heard from evidence from Dr. Shearer that she carried out or instructed further investigations, and I see there that you've detailed radiology, histology, and so she's given evidence about all of those things.
Excellent.
Did you also consider her information about those and the reports that she received?
Yes, absolutely. It's all potentially relevant.
Right. So as part of your consideration of the position, did you look through the reports by the individual specialists who'd carried out tests and further investigations in relation to Mr. Bayu?
I did in terms of histology, so looking at the samples of organs under the microscope, I carried out my own examination of the same material.
So I was going to say, there you say I've examined material prepared for microscopy from multiple tissue samples taken at the first post-mortem examination. So were these slides that were sent to you?
Yes, exactly. So that's Dr. Shearer's accession number quoted, F15542. So that is a unique reference to those tissue blocks for that case.
So you were able to not only look at her reports and the photographs, but you're also able to look at the actual tissue itself.
Yes, exactly. I mean, it's something that obviously I have quite a lot of experience of as a not just a forensic pathologist, but also having worked as a diagnostic pathologist, were the sort of pathologists who make the diagnosis of cancer, and you've got to make sure that you get it right.
So that's something you have experience of, even prior to you becoming a forensic pathologist?
Yes, that's the primary specialty that I was trained in, was diagnostic histopathology.
And you say that you were also provided with a blocking diagram of samples taken from the heart.
Yes, which is very helpful because some bits of the heart perhaps matter more than others. And so if you know where the actual samples have been taken from, that are then processed to produce microscope slides, you can get a picture of the whole heart.
And that was further items that were sent to you from Dr. Shearer
Yeah, exactly.
that you could consider yourself?
Yeah, so that was the paperwork that came with it.
Thank you. Then you've indicated here, my own examination reveals the following.
Yes.
And I'd like to just go through that. You've briefly identified what your views were, having carried out that examination. Tell us what you found in the heart.
Yes, and I'll try and unpack this a bit because it's in sort of histology speak, really. It's not very understandable unless you're another histologist or perhaps a reporting clinician.
Thank
So
you.
the left ventricle, these are the first sections that I refer to, that is the main pumping chamber of the heart. And to all intents and purposes, it behaves like a circular structure. So it's a complete encircling pump. And those sections of that left ventricle showed some variation in the size of the individual cells. Those are called the myocytes. And some of them were a little bit big, but that's not a very uncommon finding to have that, and it's not really of any consequence. Now, I noted that there was a small area of the acute responding inflammatory cells. These are called polymorphs, but that's only one small focus, which was likely to be insignificant, might relate to the sort of final phase of resus, etc. However, the sections of the left ventricle, there was no evidence of scarring, which would be important. If there's been any previous damage to the heart, then it will scar in a whole variety of circumstances. There was also no evidence of what's termed myocyte disarray. So these are the heart cells. Instead of being nicely packed together and organised, they're all rather random in a disorderly fashion. And that can give rise to a diagnosis of a condition associated with sudden death, which is called hypertrophic cardiomyopathy. No evidence of that here. And then finally, in relation to the heart, the right ventricle, which is the lower pressure pumping chamber on the right side of the heart, and that pumps blood to the lungs, that all appeared to be completely normal. So this is a normal heart, really. I think the naked eye description of the heart by Dr. Shearer was normal, and microscopically it's normal. So this was not a death due to heart disease.
We've heard detailed evidence from Dr. Shearer that in relation to the examination she carried out regarding the heart, including microscopic examination, and she, if I'm correct in saying, she said the heart was normal.
I agree with that.
You agree with that?
Yes.
And no signs of previous scarring or damage to the heart that would be indicative of any problems.
That's correct.
Thank you. And then lungs, you talk about some congestion and patchy edema. Could you tell us?
Yes, so that
found?
tends to be the final common pathway in any form of death. The hearts just get the lungs get gummed up with blood, and then fluid moves out into the lung spaces. That's called edema. And so it's a very non-specific finding in a whole range of circumstances. So it doesn't give you the cause. And the only other abnormality I referred to there is the pleura. The lining covering the lungs was slightly thickened, and that's non-specific, but might be indicative of a previous chest infection.
So someone
And I have a
who's
feeling from the GP notes he had been treated for a chest infection previously.
Thank you. But not an infection that was there at that time?
No, all resolved or resolving.
Resolved. And would slight pleural thickening cause any ongoing problems for anyone?
No.
And then you say sparse subpleural lymphoid infiltrate. Can you explain what that is?
So that's part and parcel of the thickening of the pleura, that it's gone along with some residual chronic inflammatory cells. So no longer the acute reaction, but just left with something smouldering on from maybe months to years before.
Would that cause anyone any problems?
No, it wouldn't.
Thank you. Then you say liver and kidneys, severe congestion for both. Can you explain that?
Yeah, so that's really, again, entirely non-specific in a death. It's just when the heart terminally fails, some organs get more gummed up with blood than others, and very common to see it in the liver and kidneys.
And then pancreas, you say autolysis. What's
Yeah,
that?
so that's just the breakdown after death of the tissues. And of course, the pancreas is full of digestive enzymes. It's one of the things it does. It makes digestive enzymes. And so, of course, once you've died, they will start to digesting the pancreas itself.
Is that a normal
Another entirely normal
finding?
finding, yes.
Then adrenals, congestion.
Yes. So these are
Please.
glands that produce adrenaline, amongst other things. And again, it's the same post-mortem effect of being gummed up with blood.
So far nothing out of the ordinary in relation to a post-mortem.
Exactly. And also nothing that might account for sudden death.
Right. And then you say thyroid congestion, slightly nodular architecture, no focal abnormality.
Yes.
To explain that, please.
So he has so again, more congestion, but the architecture of the thyroid is slightly abnormal in that it's nodular, which is very common as a sort of incidental autopsy finding.
So again, nothing that you were able to find that would have explained his death.
Exactly.
Bone, tell us any...
Yeah, so, and I defer to the bone expert on this, who I think has already given evidence.
We've heard from Professor Fremont,
Yes.
who's an osteoarticular pathologist.
Yes, so mine is the most basic of descriptions there, and I would defer to him on any opinions about fracture and when it might have happened, and in what circumstances.
Right. Would you defer to Professor Fremont in terms of mechanism as well as timing?
Yeah, I mean, I think what I would say is that the rib, I think it was the first rib.
It was the first left rib.
Yeah, so we see resuscitation fractures very commonly when someone's been vigorously resuscitated, but they're almost always ribs 2 downwards, not the first rib. That's somewhat protected by the collarbone from being fractured in those circumstances. So that may well be a significant finding. He then found something quite subtle, which I'm afraid is beyond me, which is called osteocyte necrosis, which means that the bone was alive at the time it was fractured. And that, I think, is a very important finding.
But you would defer to him in relation to his views on
Completely, I
that?
would.
Thank you. Can we move on, please? Thank you. And then at the end you say brain congestion.
Yes.
Can you give us a little bit of a description about the significance of that?
I mean, again, it's entirely a terminal finding. I think there's full neuropathology in this case.
And then you say these findings are in keeping with those described by Drs. Shearer and Bouhadir.
Yes.
And so was there anything from at this stage that you found that caused you any concern, or were you conflicted with anything that the pathologist who'd carried out the post-mortem found and reported in their final report?
No, so no conflict.
No conflict there. So can I, just taking that as it is, you've looked through their report and you've looked at the slides and done your own examination of what you've been sent, including the photos. Is it fair to say that on the basis of that you were able to exclude underlying natural disease?
Yes. As is often the case with the post-mortem examination, you can say more about what isn't there as opposed to what is. But we were able to exclude a lot of things that weren't there.
And we've heard evidence, detailed evidence from Dr. Shearer in relation to the microbiology.
Yes.
And she said that there was no evidence of any infective process or infection that could have caused his death.
Yes.
Do you agree with that?
I do agree with that, although I didn't specifically reassess that.
No. And she talked about the neuropathology investigations that were, further investigations that were carried out by Dr. Smith,
Yes.
and said there was no evidence of any brain infection.
Yes.
And she said that the findings in relation to the post-mortem were consistent with cardiac arrest and prolonged resuscitation.
Yes, absolutely.
Would you agree
I
with
agree,
that?
I agree with that.
So you did consider whether Dr. Shearer did consider whether there was an underlying heart condition.
Yes.
She gave very detailed evidence about that. Was there anything that you could see that would indicate there was any underlying problems with the heart?
No.
And from what you looked at, could you see, or were you concerned that Dr. Shearer had missed anything or not done that assessment adequately in any way?
No, I thought it was a thorough post-mortem examination, and of course it was helpfully corroborated by Dr. Buheda.
Thank you. And then we'd heard from Dr. Shearer about when she looked at the external and internal findings from her post-mortem, that the external and internal injuries were minor and there was no evidence of a direct traumatic cause of death. She talked about sometimes she can see a stab wound to the heart. That's a very big explanation for someone dying.
Yes, absolutely.
But there was nothing like that here, she said.
No, nothing at all.
Would you agree with that?
I agree with that. This is not a primary traumatic cause of death in the sense of lots of fractures or letting of blood from a wound.
And in relation to the neuropathology again, I think Dr. Shearer gave evidence there was no evidence of traumatic brain injury. Would you agree with
Yes,
that?
which is important. So no brain inflammation, but no traumatic brain injury either.
Then we also heard evidence from Dr. Shearer that there was nothing that she found during the post-mortem that would have indicated that CS or PAVA spray had any bearing on cause of death.
Yes, that's correct.
And would you agree with that?
I would agree
as
with that.
well?
It's used quite a lot, but it really is fairly benign. Otherwise, I suspect it wouldn't be licensed so much around the world for use. It can cause problems. Obviously, it's very uncomfortable for the eyes, and in vulnerable individuals, it can cause what in effect is the equivalent of an asthma attack. But I don't think it's that sort of a case in any case, and there were no underlying findings of asthma in the lung to suggest he suffered from it.
So we heard from Dr. Shearer that there was no signs of any pre-existing issues with his respiratory system.
I'd agree with
Do
that.
you agree with that?
Yes.
And also that she wasn't able to find any reference in the background material she had that there were any reports of Mr. Bile wheezing or being breathless or very breathless.
No, quite.
Would you agree that there
Yeah,
was
which
nothing
would be
of that
which would be
sort?
a good measure of him getting into breathing difficulties.
And Dr. Shearer explained it's very important not just simply to look at her findings in a vacuum, but to consider the background circumstances, for the chair to look at everything and put it together.
I entirely agree.
Do you agree
So
with that?
everything's relevant potentially, including what's going on at the time that cardiac arrest occurred, and that's often the case in all sorts of deaths. What's actually happening to the person immediately before, at the time they go into cardiac arrest, and afterwards, and that gives you a bit of a clue as to what's gone on.
So the timing, what's happening at the time when someone goes into cardiac arrest, would you describe that as crucial?
Yes,
I think Dr. Shearer said it was crucial.
I agree.
And then Dr. Shearer also gave evidence in relation to her post-mortem report, and she mentioned excited delirium.
Yes,
And she talked about the up-to-date position that's been intimated from the Royal College of Pathologists.
yes,
Now, you're in the Royal College of Pathologists. Are you a fellow?
I'm a fellow.
And that's a more senior level than member, isn't it?
Yes, although I think if everybody, nowadays, if they pass the final exam, they become fellows. But when I did it, you were a member first and then a fellow. I think I should say that I was involved in some of the advice given by the college to the forensic science regulator on this issue. because we felt it was an entity that had been manufactured in North America and wasn't really never an appropriate cause of death. It describes a mode of behaviour, and I hope that this inquiry has heard from a very senior psychiatrist on that point.
We've heard Dr Shearer very helpfully took us through the forensic regulator's guidance
Yes.
From the Royal College of Pathologists, and we've also heard from Dr Lipsage, a consultant psychiatrist who's talked to us about the history of excited delirium.
Yes, absolutely, it was very helpful.
And
I mean, I was involved in advising the forensic science regulator on that issue, because I sat on one of the committees of the forensic science regulator.
And so if we've heard from witnesses that excited delirium, at least in this country, is not a cause of death, pathologically it's not something that can be tested for, would you agree with that?
I would agree with that, but I've never thought it was viable. I mean, I won't go into the complexities of North America, and I'm including the USA and Canada, versus this country or the United Kingdom in general, but it simply, in my opinion, is incapable of accounting for death. It simply describes a behavioural disturbance in someone who is drug intoxicated often. You can see it with acute psychiatric illness. But the only way in which drugs can cause primary death in those circumstances, or the main way, is through what's called hypothermia. And so their body temperature rises and all their body systems don't function properly.
Thank you. Well, I'd like to move on and turn to the factors that at least Dr Shearer, at the time of her final post-mortem report, highlighted and considered were significant factors in relation to an explanation why Mr Bio died.
Yes.
And at the time of her final post-mortem report, which was prior to the testing on sickle cell, which we'll leave for now, the two factors that she considered significant were toxicology
Yes.
and the restraint.
Yes.
And I'd like to talk about those with you.
Yes,
if I
of course.
may. So in relation to the toxicological findings, we can see from the report on the screen that you had considered the detailed findings from a number of blood samples that had been taken from Mr Bio. And Dr Shearer had explained they came from hospital samples and also post-mortem samples. And you've identified there that there were positive findings of alpha PVP and MDMA at different levels, which were noticed in the toxicological report.
Yes.
And in addition, there was the presence of MDA, which you say either is a primary administered drug or a metabolite. And I think Dr Shearer gave evidence it was more likely to be a metabolite.
Yes.
Would you agree with that?
I would accept that. It's just that sometimes when people get hold of these drug substances, they're not pure in the first place, so you can have both present in one administration.
And you say HDMA and HMMA as metabolites both identified in the urine.
Yes.
Analysis of a urine sample for androgens and synthetic anabolic steroids revealed the presence of nandrolone and metabolites consistent with recent administration of the anabolic steroid nandrolone.
Yes.
And that's something that you noted also.
Yes.
And did you see any reason not to accept that toxicological
No, not
evidence? No. And in relation to the nandrolone, we've heard that that's a steroid.
Yes.
And I think in relation to the recent administration, Dr Shearer gave evidence. She was asked to explain what was meant by recent administration, and she said, in the previous kind of few days to a week or so, steroid use is not something that we see as acutely causing people to die. What we can see is long-term effects of it, chronic changes where we can get heart damage, which we didn't see in this case.
Yeah, I agree with that.
Do you agree with
Yeah.
that as
And
well?
in fact, these drugs, I'm afraid, are misused on a grand scale internationally. And we would, if there were lots of deaths arising with that as the primary cause, we'd see it.
All right. So if it had been abused and caused long-term chronic changes, that would have been obvious from the post-mortem.
Correct. That would have manifested itself through the heart.
Right.
So the heart getting much too big, or the heart muscle getting too big, the little cells.
And Dr. Shearer said the heart was normal sized, and you've explained to us what was found by her and you. And as I understand it, you found the heart to be normal.
Yes, I agree with that.
And then we've also heard evidence from Professor Lipsage, who's talked about the impact that these stimulant drugs have on a person's state of mind. That's the MDMA and the alpha PVP.
Yes.
And he described psychostimulant intoxication resulting in psychosis, and thought alpha PVP would be the most significant
Yes.
in that regard.
I would definitely defer to him on that one.
Would you?
But I mean, he has a lot of, particularly from the past, has an awful lot of hands-on experience of treating people in a very disturbed state and having to deal with them as a consultant psychiatrist. So he's very, very experienced at the coalface, if you like, of acute behavioural disturbances of one sort or another.
We've also heard evidence from a Professor Edelstein, who's a toxicologist
Yes.
and an expert in these matters, and he talked about these alpha PVP being more likely to cause even psychosis.
Yeah, I would defer to him on that.
He also expressed the view and evidence that nandrolone may give you higher blood pressure and may make your heart more sensitive to having dysarrhythmias.
Yes.
Do you agree with that?
Yes, although the main evidence that that was likely to have occurred to an extent would be from enlargement of the heart, really, and scarring of the heart. And if there wasn't any evidence of that, I would say that he might have been more vulnerable to heart rhythm disturbances, but not excessively so, such that you'd actually see pathological changes.
Professor Edelstein said there was nothing present at the post-mortem that
Correct.
he could see that would be indicative of problems such as you've described.
Yes, absolutely.
Would you agree with that?
I would agree with that.
The chair has a report available to him from Professor Crane.
Yes, another
And-
person I know quite well.
And I believe he's also a forensic pathologist.
He is.
And,
He's very recently retired, but
right,
he's still giving opinion.
thank you. And he has said the combined effects of MDMA and alpha PVP would have predisposed to the development of a sudden upset in heart rhythm, including a fatal dysarrhythmia such as ventricular fibrillation. Is that the sort of thing that could happen?
Yes, but it's more of the background. So if that's going on in the background and you've got all this behavioural disturbance as well, then excessive restraint over a significant period becomes more relevant. So these restraint-related deaths often have stimulant drugs in the background. It's not unusual.
Professor Crane went on to say if restrained at the time he suffered cardiac arrest, and if that restraint was such as to have impeded respiration, then it would be reasonable to conclude that such restraint played a part in the fatal outcome.
I agree with them.
Now,
It is, I mean, it's absolutely fundamental to a case like this what was going on at the time. So timings, I think, as you emphasised earlier, are highly relevant to be considered.
Thank you. Dr. Shearer also gave evidence that these stimulant drugs, the MDMA and the alpha PVP, can have an effect on the cardiovascular system. So they can cause an increase in heart rate and an increase in blood pressure, and they can also cause arrhythmias. They can result in a cardiac arrhythmia that is not kind of conducive to life. Basically, the heart can't beat properly and the heart then stops and causes a sudden cardiac arrest. So any stimulant drugs, that is one of the kind of extreme complications of that. They can both stimulate the heart in adverse ways. I'm reading this slightly short.
Yeah, that's fine.
And can cause the heart to stop in a sudden cardiac arrest. She agreed that it would cause the heart rate to increase, it would cause blood pressure to increase, and both could cause an arrhythmia, where the heart was unable to pump oxygen around the body. And I asked her, if the heart stops, that will be the point at which they die, and she said yes, they're in cardiac arrest at that point. Yes. So these possible things that can happen once you've taken these stimulant drugs.
They are, although that would be much more concerning if he'd been found dead sitting in a chair at home or dead in bed, and the only positive finding was a toxicology. But it's not that sort of case. It's what's going on actually at the time he went into his cardiac arrest, and everything going on is relevant.
So would you recommend to the chair that when he's considering the evidence, he considers all of the evidence and not just simply one aspect in isolation?
Absolutely.
And she also talked about the fact there was no evidence of seizure. She said, although it's not possible to tell at post-mortem if someone had high blood pressure or their heart rate had increased, there was no evidence of seizure, and there was no evidence of any damage to the heart in any way.
Yes, I mean, I think it's very likely that whatever the circumstances precisely were, his heart rate would have been high and his blood pressure would have been high, because struggling against restraint is very, very energetic. And sometimes if you see no movement, it's what's called isometric exercise. So the muscles are doing a huge amount of work. They're consuming oxygen, putting your blood pressure up, putting your pulse rate up, but there's not very much to see. And that always has to be borne in mind, really, particularly when someone's quite physically held down.
I'd like to move on to the restraint. In the final post-mortem report, Dr. Shearer had identified that as being a matter of some significance in relation to the cause of death.
Yes.
And she gave evidence about the importance of the background, what was happening at the time. She talked about injuries identified externally and internally.
Yes.
She said those were consistent with restraint and struggle against restraint.
Yes,
Do you agree with
I agree with that.
She talked about injuries which were consistent with the application of handcuffs
Yes.
and leg restraints
Yes,
and the use of a baton.
Yes.
You'd agree with all of that?
I'd agree with all of that, yes.
She also talked about skin, injuries to skin, scraping, abrasions, lacerations, that type of thing, which were consistent with the body being moved along the ground.
Yes.
With clothing on, we talked about an injury to the trunk area. We've heard evidence that he was wearing a T-shirt.
Yeah.
But she also said it could be skin just on the ground itself because his T-shirt was short sleeved.
Yeah. But I mean, actually, you can get abrasions through light fabric as well.
So you agree that all of that could be consistent
I
with
do.
struggle and restraint? And then she'd also talked about injuries to his head, and we spoke about the fracture to the first left rib.
Yes, absolutely.
And she also spoke about petechial hemorrhages.
Yes.
Can you tell us a little bit about petechial hemorrhages?
Yeah, basically, there are little bleeds into the skin of the face, particularly the linings of the eyes, but they can occur more extensively in the skin of the face. And they're essentially due to blood being able to get into the face, but not so easily out again. And that's because the venous pressure is much lower than the arterial pressure that it puts it in there. And in circumstances of restraint, you may see them if someone's gripped around the neck, because that's an easy explanation for why blood can get in but can't get out again. But you may also see if a chest is effectively pinned. So you see them in crush asphyxia type deaths, because the blood literally can't get out of the face and the head and back into the chest because the chest is squeezed so hard.
So if there is something, a pressure of some description, or a weight of some description on the chest, that can prevent the blood coming back from the head down into the body.
Yes, and it can also force the blood back up the veins into the skin of the face.
And what happens if, under that pressure of being forced?
So the little tiny branches of the veins rupture because they can't take that pressure.
And is it the rupturing of those vessels that causes these particular
Little bleeds,
hemorrhages?
exactly. So little tiny small vessel ruptures.
And Dr. Shearer gave evidence that those were visible
Yes.
in the eye.
Yes,
eyelids.
and I corroborated that, yes.
Yes, thank you. Dr. Shearer indicated that the presence of these petechial hemorrhages could be indicative of a degree of asphyxia.
I agree with that.
Can you explain what asphyxia is?
So asphyxia just really means lack of oxygen delivery in the tissues, but in these circumstances it tends to be used to describe a term where it's due to blood being forced into the tissues in some way.
The blood's being forced into the tissues.
Yes, so it could be a sign of crushing of some sort, or squeezing the chest.
And if the chair took the view that these petechial hemorrhages were consistent with asphyxia of some sort, would that be consistent with positional and mechanical asphyxia, or
I think
just
more
one?
positional alone, so just being, for instance, flat on your front, won't give you petechial hemorrhages. It implies a degree of mechanical asphyxia. And I should say in restraint-related death, they're quite uncommon. They're not common. So when they're present, this case becomes more like a crush asphyxia, where someone's been in a crowd crush.
And so it would be more akin to mechanical asphyxia.
Yes.
And when we hear about mechanical asphyxia, what type of mechanism would cause mechanical asphyxia, which is more likely to give rise to petechial hemorrhages?
So the chest being squeezed very hard.
Right.
In fact, the trunk overall.
We've heard evidence a while ago that when doctors talk about a chest, they also include the back.
Oh yeah, it's the front and back of the chest, of
Right.
course. Yeah, you're absolutely right. I mean, that's often causes confusion in casework.
Yeah. So if pressure or weight or force was applied to the front of the chest or to the rear, to your back, could either of those be can count as mechanical asphyxia?
Yes, it could.
That could give rise to petechial hemorrhages.
Yes, exactly.
Right. And in terms of the level of force that would be required, or the pressure required, can you help us understand anything about what would be required?
Well, the easiest model is, I go back to crowd crushing really. You know, we know the sort of levels of force developing in a crowd. So it's often substantial force. But I think if you have multiple individuals applying that force, particularly if they're quite heavy, then you will develop sufficient force to get this degree of mechanical asphyxia.
And when you say multiple individuals, do you have a minimum number or not?
I think you're very unlikely to see it with one or two, although I have seen it when people have been effectively crushed by bouncers having been evicted from a nightclub. But these are huge guys applying maximum pressure to someone's trunk.
When you say huge, can you give us an idea of what,
You know,
how big?
well, over 18 stone, that sort of amount.
Right.
So over 100 or more kilos.
So if there was some evidence about weight being applied by someone who was 25 stone, is that the type of
That's the
level?
type of level, yes.
Yeah.
I mean, that is a lot of force to apply.
And if we've heard evidence that that was combined with an attempt to restrain and pressure being applied to a person, would that add to the level of force and weight and pressure?
Yes, it would. So the limbs, if the limbs are held down, that although trunk being compressed will be the most significant, the limbs can actually basically transmit force to the trunk if they're being held down and restrained.
How does that happen?
Rather, I suppose the simplest explanation I could give that would be a sort of similar mechanism would be how a guy rope works and holds up the tent pole. It's not direct force, it's just the presence of something pulling.
Right. And that would be how the arms would also apply
Yes.
force.
Also, of course, that sort of holding, being completely held down, increases struggling, which increases oxygen consumption, which then makes the consequence of the restraint greater.
So if, for example, someone was straddling legs
Yes.
and another officer was applying some weight, who was about 25 stone, and another officer had a baton being held over the arm, had pinned the arm of the person on the ground, would that combine in terms of force and pressure being applied to the
Yeah, I'd be
trunk?
more concerned about the trunkal pressure, particularly, so the 25 stone, and also the pinning of the legs. The pinning of an arm, I suspect, would be little, if any, contribution,
Right, thank you.
unless it was very high up around the shoulder region.
Probably in the area between the crook of your elbow and up here, so in this sort of area.
Yeah, so not a strong contender compared to 25 stone body mass.
All right, thank you. And in terms of positional and asphyxia, Dr. Shearer said you really couldn't take positional asphyxia out of the equation when you have it in context of all the other things that are going on. It might require less to be in that position for a reduced period of time because your heart is already under strain due to the drugs being taken and because you maybe run around and you've got a build-up of lactic acid. She said this would be a multifactorial death. We do not know what the main factor has been. I think all the forensic pathologists that have been involved in this case would completely agree with that and have all completely agreed with that. Do you agree with that it's multifactorial?
It is multifactorial, undoubtedly, but I think we're all talking about when factors are proposed, we're thinking of factors that are more than minimal, which is, a very important test as a forensic pathologist. So these are not trivial factors, these are factors that are more than minimal.
Lawyers tend to say anything that's de minimis
Yes,
or
exactly.
trivial will ignore.
So I think for us to
Anything more
include it
than
in the
that.
cause of death, we'd be mindful of it being more than de minimis.
So anything more than trivial or de minimis would be considered of significance or material.
Yes, although I would agree, how significant? I mean, to me, the most significant factors here were the restraint,
Right.
but the other factors
come
form the
to-
backdrop. And the cause of death is always phrased in this traditional manner of 1A or 1B and then 2 other. But that was only ever devised for statistical recording of causes of death. And narrative causes in this sort of case are very helpful. When the cause is multifactorial, you look at factors that are definitely acting, factors that are probably acting, and then factors that are no better than possibly acting. And this case lends itself to that sort of analysis, really.
Thank you. And then we heard in relation to the final post-mortem report from Dr. Shearer that it was sudden death in a man intoxicated by MDMA and alpha PVP whilst being restrained. And I think in your inquiry statement you've made it clear that the suggestion you would have made would be to substitute the phrase whilst being restrained with in association with struggling.
Yes,
and
I think
restraint.
that's an important component because that gives you a high oxygen consumption.
And so,
And I mean, that you can see, I've already touched on the fact that narrative cause of death is best in those circumstances, and that's exactly what we've all adopted and basically agreed upon. The only thing I've added is the struggling.
So, is it fair to say you agreed with the conclusions of Dr. Shearer and Buhadir, but you added in the importance of struggle?
Yes.
And is that in line with what you said a moment ago
Exactly.
about all the different factors?
Yeah. So the struggling is a more likely than not factor.
Integral in
Yeah,
the circumstances.
but I mean, it's very difficult to have restraint and struggling separated from one another because they're all part and parcel of the same thing. And in fact, sometimes people are not getting enough oxygen in, and of course they struggle more. And that may be misinterpreted as resisting restraint. And in fact, I suspect even if you held someone down as meek and mild, they would struggle.
Mm. And we've heard evidence from Dr. Shearer that she agreed with your suggestion and has adopted that now.
Yes.
Uh,
Well, that's helpful when really all the experts from the same specialty agree.
It is, and helpful to the chair also.
Exactly.
So, you talked about earlier this morning about you need to know about how things work normally when
Yes.
things are working properly. So, from a physiological point of view, you understand how they work. They're supposed to work, so you can then identify how if they fail or they stop working properly.
Yes, exactly.
I think you said if they go wrong.
Yes.
I'd like to ask you some questions about how things work normally, how they're supposed to work.
Yes.
Just so that the chair can have a very clear picture about that. So what we have here, what we've heard evidence about, is that an apparently healthy male, Mr. Bio, he was in his early 30s. He was 5 feet 10 inches in height. His weight was 12 stone 10. And he had a BMI of 25.6.
Yes.
And can I ask you, to what extent does your BMI give an indication of your level of health or fitness?
You have to be a bit careful about this one because Olympic oarsmen will have probably quite a high BMI due to the amount of muscle mass they have. So it's a very crude sort of assessment of how people are.
Right.
But, you know, he's not into the overweight or obese category at all,
Thank you.
particularly as he's quite muscular.
And I'd like to get a picture for the chair about how a person's respiratory system
Yes.
would work when it's not impeded in any way. So it's working normally and in a healthy way. Could you explain that to us, please?
Yeah, so the idea is to get oxygen in and expire carbon dioxide. And you do this through breathing, which you do a few times a minute. And so you take breaths in and you take breaths out. And in your lungs, air exchange takes place and the oxygen comes from the air and gets into the blood. And at the same time, really, the carbon dioxide comes out and gets into the alveolar air spaces to then be expired with each breath. And so it's serving two useful functions, breathing, is getting oxygen in, getting carbon dioxide, the waste product of respiration, out.
So when we breathe in, we're breathing in oxygen into our lungs,
Yes,
and a process takes place within the lungs which allows you to then breathe out carbon dioxide.
yes.
And what happens to the air once it's into your lungs?
So that's where in the little tiny air spaces called alveoli, oxygen can actually get directly into the bloodstream and carbon dioxide can get directly out.
So from your lungs, oxygen will go into your bloodstream.
Yes.
And where does it go once it's in your bloodstream?
So it's then circulated back to the heart and then pumped around the body.
And does the heart pump it round all of the body and including the brain?
Yes. Yeah, so some organs are more sensitive than others. The brain and heart are the most sensitive, and probably out of those, the quickest to suffer if you run out of oxygen is the brain.
And if your brain is suffering from a lack of oxygen or a deficit of oxygen, what happens to your body?
So ultimately, you actually irreversibly damage the brain function. And that's why when someone goes into a cardiac arrest, where the circulation has failed as well as the breathing, you don't have very long to get resuscitation going, essentially to keep the brain alive.
Now, we've heard evidence about something called hypoxia.
Yes.
And can you explain to us what hypoxia is?
Yes, so that is a lack of oxygen delivery to the tissues. And so there may be what's called hypoxemia, which is a lack of adequate oxygen in the blood. That can happen in a whole variety of ways, but failure to get oxygen into the blood is the most important.
So a lack of sufficient oxygen into your body.
Yes.
And
then at the end organs as well, so all the tissues need to continuously be supplied with oxygen. And so that's through oxygenation of the blood and then circulation.
so if you're not getting enough oxygen, How does the body react to that initially?
So various organs react in various ways, but one of the consequences of a lack of oxygen in the blood may be the brain damage I've just described, but also the heart may become irritable and may be vulnerable to heart rhythm disturbances, which can ultimately culminate in cardiac arrest.
Right. And if your body was suffering from some sort of deficit or inadequacy in terms of the quantity of oxygen it was taking in, how would you react as a person to try and get more oxygen in?
Well, at the worst end of it, you go unconscious. So, but on the sort of run up to that, you might well struggle and panic and desperately try and get oxygen in.
And how does your body try desperately to get oxygen in?
Just struggling against whatever's stopping it getting in would be the mechanism in those circumstances.
Okay. And you've said at the worst end it become unconscious. Why would it become unconscious? What would that be a sign of?
That's a sign of the brain being affected by the lack of oxygen.
Right. And so the brain shuts down in some way, if I can use a layperson's term?
Yes, and in fact, ultimately, if the heart then stops supplying blood to the brain, and which means you're on a very slippery slope to basically being dead. The breathing also stops when the heart stops, whereas if the breathing stops, the heart won't stop immediately. So you've got a good store of oxygen in your bloodstream and in your lungs, which will keep you going for a while if your breathing stops.
Right. Can I just go over what you've said there? When the breathing stops,
Yeah.
what does that signify in terms of changes to your body?
So
Did you say the heart?
if your let's turn it around the other way. If your heart stops, your breathing will stop very soon afterwards. But if your breathing stops, your heart won't stop until it runs out of oxygen, which will usually take minutes.
So if your breathing stops and you're not taking any oxygen in at that stage, your heart will stop quite soon after that.
No, if the breathing stops due to some other external factor, you have a while where your blood becomes more lacking in oxygen. Where unless that's reversed, ultimately you'll have a cardiac arrest.
Right.
But what I'm saying is if you have a cardiac arrest, because the brainstem needs a good blood supply, really very soon after a cardiac arrest, your breathing will stop.
If you become unconscious because of inadequate oxygen in your system,
Yes,
the heart will still continue pumping
it will.
for a while to allow
Because it's able to go on extracting oxygen down to when there's not very much oxygen in your blood.
Right. So there will be a window of opportunity to reverse the effects of that lack of oxygen.
There will.
Be?
And although we always see portrayed on television resuscitation being successful, that reveals that window of opportunity is neither very long or very likely. It's possible, which is why all efforts are made to resuscitate people.
And is there a set time, or is everyone different?
I think everyone's different, but if you don't commence adequate resuscitation with oxygenation, within a minute or two, you're running the grave risk of brain damage.
Right. And is that why people start CPR very quickly
Exactly.
once you stop breathing?
Yes.
We heard evidence a while ago about a situation where it's not as simple as just breathing or not breathing. There will be a process where maybe you're not breathing normally.
Yeah, so you can have inadequate breathing in these circumstances. I agree with that. So, and sometimes when people have been hypoxic, so lacking oxygen in the blood, when they come round a bit more, they may not breathe adequately.
Right.
Probably due to the brain damage they've had from a period of severe lack of oxygen.
So you can be breathing normally, not breathing normally, and then not breathing.
Yes,
Is
so they're
it
not
a
breathing normally.
process?
Yeah, exactly. So it may be shallow breaths, it may be only intermittent breaths.
Right. Is it common? Is it normal for someone to go from breathing normally to not breathing at all?
As a primary stoppage of breathing, that is quite unusual. There are a number of medical causes that can do that. but the commonest cause of stopping breathing is your heart stopping and not supplying your brainstem with blood.
So more common for there to be a process
Yes,
where the breathing changes from normal to not breathing.
yes, exactly.
Thank you. I'd like to ask you about possible causes of hypoxia.
Yes.
So possible causes where there is that inadequate supply of oxygen and that sort of deficit builds up. Now we've heard about positional asphyxia,
Yes,
and we've heard evidence from a number of witnesses. Dr. Shearer talked about people being slumped in a position where there is an inadequate ability of the body to take
so
in
that would be
oxygen.
the more important element there would actually be obstruction of the airway. So if you're in a slumped position, particularly if you're affected by disease or drugs, then your airway may be vulnerable, and that would be the primary source of hypoxia.
And we've heard from Professor Lucas yesterday about a case where someone had slumped over a couch. I think he said they were drunk and their neck was leaning over the arm of
Yes.
the couch, and that had caused positional asphyxia.
Yes,
Now,
but of course the most important underlying factor there would be the alcohol intoxication.
that's what caused them to be slumped.
Exactly. So you could lay a fit, healthy person on their front. You could even slump them slightly, and they wouldn't get into any sort of difficulty that would cause their death. So it's the acute intoxication that's relevant there.
And would a healthy person be able to just simply move
Yeah,
into a
exactly.
more comfortable position,
Yes,
even if they were asleep?
even if they're asleep, yes. So fortunately, you wouldn't expect someone to just get into a bad position in their sleep and then die, unless they had severe chronic lung disease.
Something wrong with them,
Something really badly wrong with them, yes.
or they'd taken drugs or
Or they've
alcohol.
taken drugs or alcohol, exactly.
Now, can I ask you about the use of the word asphyxia there, positional asphyxia?
Yes,
Because I'd like to be clear about the distinction between hypoxia and asphyxia.
yes.
And can you help me understand that?
Yeah, they overlap, but basically asphyxial mechanisms are those involving lack of adequate delivery of tissue oxygen, and so that overlaps considerably with hypoxia. But we tend to use the term asphyxia for specific circumstances like compression of the neck or smothering, suffocation, that sort of thing. And then there's what's called internal asphyxia, where the problem is due to poisons of one sort or another, cyanide, carbon monoxide poisoning. That actually stops oxygen getting to the tissues.
We've heard a witness a while ago now talking about chemical asphyxiation.
Yes,
Is that the sort of thing that can stop people breathing?
yes, exactly.
Is it fair to say that hypoxia is where there's a deficit of oxygen, but asphyxia is where that has maybe been the sort of end point of that lack of oxygen?
I think asphyxia is one of the causes, one of the root causes, but all these chemical mechanisms also apply.
And when you say cause, is that cause of death?
Well, causes the hypoxia, the lack of oxygen.
Right.
So there are asphyxial mechanisms, but of course, I mean, most people wouldn't really use the term chemical asphyxia because it's really poisoning due to whatever the chemical was.
We've also heard evidence about mechanical asphyxia, and you've described that to us today in terms of pressure on the trunk.
Yes,
Um,
and that's what applies here. I think it's a mechanical type of asphyxia, and support for asphyxia here is the presence of the petechial hemorrhages identified by Dr. Shearer.
Thank you. And then the other possible causes, would they include things like infection
Not very likely to cause asphyxia in these circumstances. I mean,
or hypoxia?
hypoxia could certainly be the result of infection, yes.
If-
So pneumonia,
I was just
severe
about to say.
pneumonia,
Yeah. So something that affected your lungs, like pneumonia,
yes.
could cause hypoxia in the sense that you can't get oxygen into your lungs.
Absolutely, and everybody's probably very familiar with this now from COVID-19. So that causes a very strange effect that's ill understood, which is called silent hypoxemia. The hypoxemia reflects the fact the blood is often severely lacking in oxygen, but you wouldn't know there's anything wrong. They just go bluer and bluer, because of what's going on. And the reason for that is probably because the brainstem is also affected in some way, so it doesn't detect the lack of oxygen in the blood. And we have some good detection mechanisms for lack of oxygen in the blood, and we'll do everything like breathing harder to try and cope with that, but also detection of carbon dioxide building up, which is what keeps you breathing. That's the primary driver of breathing that makes you breathe, because the carbon dioxide is building up. So if you were to hold your breath, the overwhelming desire to break the breath hold would come from the build-up of carbon dioxide.
And is that a message from your brain saying you have to
Exactly.
breathe? Yeah.
Exactly.
And
So the free divers can get around this. They can go underwater for a long time because they resist that effect, but they also take in a very deep breath of air before they go, so that there's plenty of space in their lung for carbon dioxide to come into while they're underwater.
And that's why if you were in hospital with COVID, for example, they can monitor your oxygen levels and the levels in your blood.
Yes, exactly.
Whereas people at home maybe weren't able to do that.
No, I mean, there is you can look at your saturations through one of these finger measures, so people are using that as a sort of screen. And I know the ambulance personnel use that to see whether the person's hypoxic, because that's an important determinant as to how bad things are.
And you said that might not even be readily visible to the person or their family.
No, not at all.
And could a pre-existing condition perhaps cause hypoxia?
Yes, it could.
So something like asthma? Could
Asthma, yeah, acute asthma attack could cause hypoxia, or any sort of chronic lung disease.
I mean, in this particular case, there was no evidence of infection or any pre-existing condition that would impact on or cause hypoxia.
That's
in Mr.
correct.
Byron.
Yeah, that's my understanding.
And if you have hypoxia, you've talked about the brain sending a signal sort of to the body to breathe. Is it reversible?
Yes.
Hypoxia.
Yeah.
And
If the cause is reversible, but obviously if it goes to a point where your brain is damaged, it may be very hard to reverse it.
so for the person slumped on the couch, if they're healthy, they could sit up or move position.
Yes.
Same with positional asphyxia or mechanical, they could move out of the way or remove the obstruction, or they could hopefully be healed from the infection or whatever.
Yeah, exactly. So given antibiotics, maybe support with oxygen administration in hospital, all that sort of thing.
So that's all reversible.
Yes.
And you say that up until the point of sort of maybe once your brain is damaged, I'm interested in the tipping point, if I can use that, or the point of no return. The point after which you've been hypoxic for a certain period, or it's of a certain sort of severity, that it's no longer capable of being reversible.
Yeah, and I think, I mean, obviously I've been involved in a lot of these sort of cases, and the most important tipping point is the occurrence of cardiac arrest. Once that's happened, you're even with good resus, your fate is sealed.
And what happens during a cardiac arrest?
So your heart goes into a completely ineffective rhythm. There are a number of rhythms that it can undergo, so it can have ventricular fibrillation, people are probably familiar with. It just wobbles in every direction at once in an uncoordinated matter. And that's the good thing about that is it's reversible with a defibrillator, which gets it back to work. But in many circumstances, the final common pathway may be asystole, where there's absolutely flat line on the ECG, and then you've got to really get that heart going again, which, you know, would take some doing in drugs, administration, etc.
Right. And can you explain the difference to us between respiratory arrest and cardiac arrest?
So that's just breathing stopping.
All right. So if...
But as I mentioned earlier, a cardiac arrest will stop your breathing very rapidly because the brain needs blood.
So respiratory arrest is breathing stopping.
Yes.
And is this the moment in time between that you talked about a moment ago, where a person could be unconscious, they've stopped breathing, Is that them in respiratory arrest?
Yes,
But their
exactly.
heart
Well,
continues
if
beating
their heart's
for a
continuing
while.
to function, yes, and the most important thing there would then be to support their airway, rescue breaths, administer oxygen, all those sort of things would be helpful.
So is there a very short period of time between respiratory arrest and cardiac arrest?
Yes, I mean, it might be a minute or two, but if you've been struggling and you've been very active and you have a very high oxygen demand, the time gets shorter.
And we'll talk about oxygen demand in a moment. So this period, if someone is unconscious and they have stopped breathing, would that be an indication of respiratory arrest?
Yeah, well, it may be cardiac arrest because the
Or it may be
cardiac arrest
cardiac.
may have been the cause of the stoppage of the breathing. So it's very difficult in casework in general, and indeed it's very difficult for emergency services to know what the first event has been, which is why you really want to monitor everything, see whether their heartbeat is actually working and whether they're breathing or not.
And if there is a pulse detected at some point, does that indicate that the heart is still working
Still
to some
functioning.
extent?
Yeah, absolutely. But the trouble with that is that if there's an evidential issue about feeling a pulse, it's really difficult in fraught circumstances to be sure that it's that person's pulse and not your own fingertips.
Oh, really?
So it can be quite difficult. And so I think most of the advice is if you think someone might be in cardiac arrest, you should probably start cardiopulmonary resuscitation. Certainly important to give the rescue breaths if they're not breathing.
So as soon as they are seen to be in respiratory arrest or cardiac arrest, important to start the CPR straight away?
Yes, absolutely.
And is that immediately, effectively?
Yes, you should. You know, that's a very grave state of affairs, whether someone's in respiratory arrest or primary cardiac arrest.
What if a person's just simply unconscious but breathing or noticed to be breathing?
That's obviously more perilous, but they shouldn't be unconscious, so you'd want to very quickly know what the cause of the unconsciousness was, and then they'd be vulnerable to airway obstruction, which would keep them unconscious.
So if the person was just simply unconscious but noticed to be breathing, would you start CPR at that stage or
Well,
not?
you'd start rescue breaths at first, and then you'd want to make sure that you had a good way of determining whether they had a pulse or not.
Right. I'm conscious of the time. We often have a break at this stage.
We'll take a 20-minute break at this point.
Thank you, sir.
Graham.
Hello again. Just before the break, I asked you about a scenario where a person was unconscious but noticed to be breathing,
Yes.
and asked you about when you would start CPR. And your answer was you would start rescue breaths at first, and then you would want to make sure you had a good way of determining whether they had a pulse or not.
Yes.
I'm interested in this idea of rescue breaths, and I wonder if you could just give me a little bit more explanation.
Yes, of course. So at its simplest level, you could give mouth-to-mouth resuscitation, which is not as good as using some sort of device like a bag and mask, because when you breathe out, your own breathed out air is lacking in oxygen and is higher in carbon dioxide. So it's not the best breath to give someone to rescue them, but it's better than nothing. So if they're not breathing adequately or in full-blown respiratory arrest, it has a potentially useful effect.
And is that a situation where they're not breathing adequately?
I mean, if they're not breathing adequately, you'd obviously need full emergency support, but it's actually quite hard to recognise, especially if you're a lay person, whether someone's breathing adequately or not.
So in terms of the way of managing that situation, if they're unconscious, that to you would result in these rescue breaths or mouth to mouth?
If they're not breathing as well, yes.
Yeah.
I mean, that really is an acute medical emergency.
If they are breathing or seen by a layperson to be breathing, would you start rescue breaths then? Or?
No, not if they're breathing. But if they're unconscious, you want to know what the cause of the unconsciousness was. And obviously, in these particular circumstances, if they've just been heavily restrained, it would rather speak for itself. Right. That might be relevant.
And in terms of deciding, for a layperson, it might be difficult deciding whether they're breathing or not breathing normally. Is that a difficult assessment for a layperson to make?
It could be. I mean, people hold a mirror under the nose, or you look for chest movements.
So if they're breathing normally, you'd want to find out why they're unconscious.
Yes.
If they're not breathing normally, you would start mouth to mouth or rescue
You would
breaths.
consider it. The trouble is, it would all be degrees. So if you were in full-blown respiratory arrest, so not breathing at all, that would be very obvious. If they're not breathing adequately, it would be a much more difficult decision for a layperson to make as to what exactly to do.
Right. And all of this being done within a short period of time.
Exactly.
I'd like to go over your own conclusions about the circumstances that we've heard evidence about.
Yes.
And you've addressed all of these points in your inquiry statement in different parts and also in your report. If you don't mind, I'd like to go through things in a certain order with you.
I'd be delighted, no problem.
If I may. So we're dealing with a male in his early 30s. We spoke before about his height and his weight and his BMI.
Yes.
Can I just be clear that there's some references in your statement, you've been asked about seasonal rhinitis or hay fever.
Yes.
And you've said in your statement that is not relevant to the case at all.
Absolutely.
So if others have also given statements saying hay fever, insofar as that might be something that Mr. Bio suffered from, that has absolutely nothing to do with this.
That's right.
Thank you. And insofar as he may have been checked for sleep apnea,
Yes.
again, I think in your inquiry statement 230 and in your supplementary statement at paragraph 24, you again say that's not relevant at all to this situation.
Yeah, I think I did see some of the original notes now that I've seen the GP notes in relation to that problem. And it seemed that he had noisy snoring, which is actually quite common. Mm-hmm. But I don't think the sleep experts were wholly convinced that he had full established sleep apnea. Because what happens then, you have to have significant periods of not breathing and very disturbed sleep, and you wake up very drowsy in the morning. You just don't feel like you've had a good night's sleep.
And so,
But I mean, there may be other experts before the inquiry who give more relevant evidence than me on that point, but I didn't think it was a strong contender.
Nothing we've seen so far indicates that played a part in the events at Hayfield Road.
No.
Would you agree with that?
I would agree with that.
And then we talked briefly earlier about sickle cell trait.
Yes.
And we've heard evidence from Dr. Shearer about this, that wasn't a part of her final post-mortem report, but then subsequent tests were carried out at a later stage. And there was a further supplementary post-mortem report where she noted that the results of the test were that Mr. Bile was a carrier
Yes.
of sickle cell trait. And have you seen that?
Yes. And that, by and large, I think I mentioned earlier that could get into problems if you became hypoxic, which is why they tend to check it before anyone has a general anaesthetic.
And we've heard yesterday from Professor Lucas about the implications of sickle cell trait
Yes.
in relation to Mr. Bio. And we also heard evidence from Professor Lucas in connection with reports from a Dr. Swaya.
Yes.
Sorry, my pronunciation will no doubt be appalling.
No, it's fine. I can understand it perfectly, so that's
right.
absolutely fine.
Well, that's Dr. Elizabeth Swaya. And I'm very interested in a paragraph in your inquiry statement. I wonder if we could begin just to put it into context. So it's between paragraphs 142 and 150. Let's start with 142, just so we can put all of this into context, but it relates to the sickle cell trait.
Yes.
And you'll see that there was reference just in the page above to Dr. Swaya's report. If we just go down slightly. You were referred to her supplementary report. This relates to sickle cell. And that's from May 2018. And then if we can look at 142. She says there is a significant body of other evidence summarised that sickle cell trait can cause sudden cardiac death, usually in very demanding physiological settings such as intense physical exercise. So as a sort of primary position, if you may, she recognises that sickle cell trait can cause sudden cardiac death.
Yes.
And I think Dr. Shearer also gave evidence to the inquiry about army recruits who have died.
So, exactly. There were publications, a publication called Military Medicine, and when they had army recruits, often who are not very fit, but they had to do the usual thing you have to do in the army of, running absolutely miles in sometimes in hot conditions. They had some sudden collapses, and they had this condition called exertional rhabdomyolysis. So normally with sickle cell trait, you won't sickle unless the conditions are really difficult, such as hypoxia. But when you have very vigorous exercise, you can get this condition. And when you have rhabdomyolysis, your peripheral muscles break down and release potassium into the blood. And that can be lethal because potassium is potentially a heart poison.
Right. So that can have a detrimental effect on the heart.
Yes.
We'll come on to that in a moment.
So it is a factor to have in mind for one of the factors.
And Dr. Shearer also spoke about a situation such as someone trying to run a marathon without proper training.
Yes, well, that would be very similar, except that you, in military setting, you tend to get forced to run the equivalent of a marathon, but it has the same effect.
And then if we carry on, 144, please. Again, referring to Dr. Swaya's report, she notes that there was genetic testing carried out. Mr. Bile was a carrier of sickle cell, i.e. had sickle cell trait, and she reconsidered the likely causes of death. A combination of exertion, including both walking or running around over several hours, preceding the restraint by police, and his struggle against restraint, and alcohol consumption would have led to dehydration. The exertion would also have led to hypoxia, decreased blood oxygen levels. During hypoxia, anaerobic respiration occurs, producing lactic acid, leading to acidosis. And I'd quite like to go through this. This is from Dr. Swaya's own report
Yes.
in 2018.
Yes.
And she talks about exertion, including walking, running around over several hours, preceding the restraint by police and his struggle against restraint. Now, we'll come on to the evidence we've heard in a moment. At the moment, the inquiry doesn't have evidence that Mr. Bio was running around over several hours preceding the restraint.
No, so that's a false premise.
So it's a false premise. And then alcohol consumption would have led to dehydration. What's your comments about that in light of the toxicology you've seen?
I mean, there wasn't any positive finding of alcohol, so I'm not sure quite where she's got that from. Right. It may be historical in relation to these events.
We did hear some evidence. We've had, the chair has an inquiry statement available to him indicating that a friend had maybe seen Mr. Bio buying alcohol, maybe taking some alcohol in the hours prior. But we've heard from Professor Edelstein that he had no alcohol in his system.
Yes.
And so if there had been alcohol consumed, it would have been out of his system.
Yes.
And that's from the samples that were taken, both in the hospital and post-mortem. And then she says the exertion would also have led to hypoxia, decreased blood oxygen levels. Will you agree with the idea that exertion can cause decreased blood oxygen levels?
Not really, no.
And what do you mean by?
Well, our systems are designed to maintain normal oxygen if we exert ourselves. Right. You won't tend to go hypoxic simply with exertion. So
would walking around cause hypoxia?
Not unless you had some underlying significant chronic disease.
Right. So we heard from Professor Lucas yesterday about normal sort of daily events. You wouldn't expect to have issues with sickling. Would you agree with that?
I'd agree with that, yeah. The real thing you want to try and detect in people who have sickle cell trait is to do anything to stop them getting hypoxic. And of course, most of us, as I say, wouldn't get hypoxic with ordinary daily activities or even quite extreme exercise.
Right. So if exercise caused hypoxia, what sort of level of exercise are we looking at?
I think, excuse me, I wouldn't expect exercise to cause hypoxia at all, but in other circumstances, such as in combination with restraint or squeezing of the chest, that's when it might cause hypoxia. But exercise of itself in a healthy person shouldn't cause hypoxia.
And I think Professor Lucas yesterday talked about temperature could have an impact. We've heard about the example of the recruits in the desert from Dr. Shearer.
Yes.
So
that's more an effect of, of basically hyperthermia, so getting very, very overheated.
And Professor Lucas talked about the impact of that combined with dehydration can also cause issues with sickling.
That's true.
And then it says at the end of this paragraph, during hypoxia, anaerobic respiration occurs, producing lactic acid leading to acidosis.
Yes.
And do you agree with that?
Yes.
Can you tell us a little bit more about that process, please?
So it's what stops you exercising too hard if you're not very fit. You get cramp, pain in your muscles, and you may get a lot of cramp the following day. And it tends to be locally produced lactic acid, and that's because it's the wrong sort of metabolism. The metabolism you want going on in your muscles when active is called aerobic. A lot of people who train in the gym know about these different aspects of exercise. So aerobic metabolism, where you're breathing adequately, will not produce lactic acidosis, but anaerobic, where you're not getting enough oxygen to the muscles, so they're still capable of functioning, but without much oxygen, that's what gives you lactic acidosis. And it's very likely, it's why I've, for instance, thought in this case, the struggling is a very important component here, because you may well have evidence of lactic acidosis from extreme muscle exertion.
And that production of lactic acid, is that reversible?
Yes.
How is it reversible?
A number of means. It may just the passage of time, so you may breathe off carbon dioxide, which is a source of acid in your bloodstream. So or your kidneys may be able to help reverse it, but it's not going to be instantly reversible. It needs things to go back to normal.
Right. And it says during hypoxia, the production of lactic acid leads to acidosis. Once that process has started, where the lactic acid is built up and you've developed acidosis, how does that, in terms of we talked earlier about the tipping point or the point of no return, does this have an impact on
Yes,
hypoxia?
it does. So the heart doesn't like to work in an acid environment. If the blood is acid, whether it's due to lactic acid or some other acid forming in the blood, that makes heart function less effective.
And Dr. Shearer said she can't do a test at post-mortem for lactic acid.
Yeah, I think you may be able to, but it's very difficult. In someone who's had a prolonged cardiac arrest, it would build up anyway, so it becomes uninterpretable what the result is.
Would it be difficult to distinguish between lactic acid prior to the cardiac arrest
Exactly
and
right.
after?
Yes.
And then see at paragraph 145, I think you mentioned there that the issue about the alcohol consumption, and you comment that the toxicology was negative. So it's not an appropriate thing to include in the factors.
Not really. I don't think any inquiry is assisted by possibilities. You want either probabilities or actualities.
Right. And then moving on, 146. You comment that she dismisses the importance of restraint, but note that she's not a forensic pathologist.
Yes. Which is important. We each have to stick to our own specialty. And, I'm a forensic pathologist, Dr. Buheda and Dr. Shearer are forensic pathologists. So they probably not infrequently have to deal with cases of significant restraint. And it is important to be familiar with your specialty.
And I think both you and Dr. Shearer recognise the importance of considering all the circumstances, not simply the scientific or medical findings.
Yes, and of course a lot of that is entirely hypothetical. Could have been this, could have been that.
Right, thank you. And then the doctor continues, it was quoted in paragraph 147, this markedly increased acidity, presumably becoming very severe during the restraint process, coupled with dehydration, would have caused sickling of red blood cells in Mr. Bio, despite him only having sickle cell trait. Now, subject to the comment you've already made about the alcohol and the dehydration, would you agree that increased acidity would become severe during the restraint process? It
may well have done, yes. There's a lot of anaerobic exercise. So this sort of, it's called isometric exercise, where you see no movement, but there's an awful lot going on in the muscles.
Right. Then 148. Dehydration as a factor in causing the lactic acidosis would feature here. The most important factor is the totally inappropriate levels of exercise. People who suddenly run a marathon without being trained properly would get lactic acidosis quite early on. Now, this is your own comments in
Yes.
your inquiry statement. Could you just give a little further explanation here?
So if you're not trained, you would very likely slip into that anaerobic metabolism if you try to run a marathon. I suspect if most people who weren't very fit tried, they just fail. They'd give up. So all these factors would operate on your body to make you stop.
And that's if you're healthy and you're not under the influence of alcohol or drugs.
Yeah, particularly drugs.
Drugs.
You would tend to be driven by stimulant drugs.
Then 149, again we go back to looking at the doctor's report, and she said in 2018, this would have begun to block small capillaries, including those supplying the myocardium, the heart muscle. So this is her reference to the effect of sickling.
Yes.
You talked about small capillaries in the body being blocked earlier. And she talks there about the drugs being taken, the MDMA and the alpha PVP, and the exertion would both have substantially increased the heart rate and strength of the heart's pumping, known in medical terms as stroke volume. This in turn would have increased the heart's muscles requirements for blood due to increased demand for delivery of oxygen. This increased demand would have been difficult to meet because of red blood sickling due to the acidic, highly concentrated, dehydrated blood. And you say, I agree with this opinion. I'm interested in your views on this explanation of the process of sickling.
Yes, so that would be how it could cause problems in the heart.
Right.
But I think she's, I think I go on to say the problem is that sorry, I can't remember how to pronounce her name properly.
I think I've been told it's Swire.
Okay, Swire. I say she has not realised the presence of sickling in someone with sickle cell trait means they're being pushed to the limit physiologically. And I think that's the important point here.
And so this is in paragraph 150. Let's have that whole paragraph on the page, please. Oh, well, we might not get the whole Let's start at the beginning. The problem is that Dr. Swire has not realised that the presence of sickling in someone with sickle cell trait means they have been pushed to the limit physiologically. Can you help the chair understand what you mean by pushed to the limit physiologically?
Yes, so something that's totally abnormal for any sort of individual in any circumstances. They've been pushed to the limit physiologically. So what it means is if they get hypoxia, I think that's what they go on to say, that will be bad because that could then precipitate sickling. But as I mentioned earlier, we wouldn't expect ordinary individuals to just become hypoxic. The only way you'll become hypoxic if you go up a very high mountain.
So going to the gym might create lactic acid in your system, but it's reversible and it wouldn't cause you to become hypoxic.
Yes, exactly.
But the examples that we've heard of going up a mountain or running a marathon or doing army training in the desert, these are the sorts of exertions that would cause an issue?
Well, could cause an issue,
Could
yes.
cause an issue.
Yeah.
Yes, they wouldn't cause an issue in everyone.
No,
but they may,
only in people with sickle cell trait.
only in people.
And even then, not every time, because the Sickle Cell Society would make it very clear that you live a normal life with sickle cell trait.
So it would just be some people depending on the circumstances.
Yeah, exactly.
You say, I can equally argue that the presence of sickling actually provides strong evidence for hypoxia and lactic acidosis as a result of restraint. I noticed this in Professor Lucas's report too. We don't disagree on the findings, but the interpretation is very one-sided in terms of what she says. That's Dr. Swire.
Yes.
So can we just look at the line above, please? We can go back to page 37, paragraph 150. You say, I can equally argue the presence of sickling actually provides strong evidence for hypoxia and lactic acidosis as a result of restraint. I think you've commented on this earlier. I'm interested in this line.
Yeah, I think what it means is that he had an independent marker within his system for hypoxia, which was the fact he carried sickle cell trait. And so if he was hypoxic, that might cause sickling. So in a way, to me, this helps to support any argument that he's been rendered hypoxic and that has caused sickling.
So he's been rendered hypoxic. That process has resulted in sickling.
Yes.
That has been tested, and Professor Lucas gave evidence that there were about the quantity of sickling.
Yeah, indeed. I think he felt, and he sees quite a lot of cases of sickle cell disease of one sort or another and sickle cell trait. He felt that there was quite an exceptionally large number of sickling cells at post-mortem. The problem is anyone who even carries sickle cell trait, you may see sickling in their post-mortem organs anyway, because of course at the time of death the person becomes hypoxic, so that causes cells to sickle in any case. So you have to be careful that it's just not a false positive.
I think the chair heard evidence yesterday from Professor Lucas, and as I understand it, he did talk about there being levels of sickling for someone with sickle cell trait after death, and that would be apparent.
Yeah, and he felt this was way in excess of that, was my understanding.
I think the word he used in evidence yesterday was massive.
Yeah.
And he talked about the different organs which had sickling in, and in lungs it was in 3 out of the 6 samples he checked.
Yeah.
So in your mind, when you're thinking about the impact of sickling, am I right to say you think that process, having been found as a part of the investigations for post-mortem, is evidence of itself of hypoxia having taken place?
Yes.
Thank you. Now, I think in your inquiry statement you had looked at Professor Lucas's original report, which was from, I think, 2018. And you've talked to us about the significance of sickling and his report. Can I ask you to look at something that Professor Lucas spoke about yesterday?
Yes, of course.
He's reviewed his opinions since 2018, and I'd like his inquiry statement to be up on the screen. SBPI 00314, and it's paragraph 25. Now, he gave evidence about this yesterday as well, so he's confirmed that this is his current view on the matter. So he said in his inquiry statement, reflection on my report 4 years on, I don't think sickle cell trait is quite as important as I thought it was, perhaps back in 2018. That's partly influenced by lots of discussions I had with coroners in England about how we should be phrasing causes of death. What is important and what is less important? What goes into one, which is the main thing, and what goes into part 2 as a contributor. If I was doing this case again now, I would move the reference to sickle cell trait part 2 of the death certificate. I would not frame the entire story of his death around sickle cell trait. I would simply put that in on the end as a small extra factor, as explained earlier, that it may well have shortened his life expectancy by a couple of minutes given the stresses he was under at the time. Paragraph 26. Again, that's guesswork. I can't quantify that seriously. No one can. This is a very recondite field. I've been involved in a number of inquests over deaths involving sickle disease generally in patients with sickle cell disease or trait. On many occasions I provided opinions that sickling played no role whatsoever, but conversely I've seen ones where it absolutely definitely did, and if they hadn't had sickle, they probably wouldn't have died when they did. I don't think this case comes into that category. So you can see, we can have maybe the paragraph 25 back on the screen, please.
I think that's a very helpful re-evaluation. And if you were to look at the General Medical Council who regulate all doctors, you would find that they are very keen on people reflecting. And that's precisely what Professor Lucas has done. He's reflected. And we're strongly encouraged to do reflective practice.
Now, he mentioned yesterday that he had spoken to you at some point. He couldn't remember when, but he'd had a conversation with you. Do you remember speaking to Professor Lucas about sickle cell?
I might have done. The trouble is I've talked to him quite a lot about sickle cell because he is one of the people to go to for sickle cell disease, but I may well have talked to him about this.
How often do you speak to him?
Less so now, because he used to come in St Thomas's mortuary once a week, often when I was there, and so we then talked then.
He spoke about you talking to him about this, his view in this case, and let me just see that you'd had a conversation, and he couldn't really remember the context of that conversation, and he thought that it had some impact on him, being caused to reflect on his opinion. Sorry, thank you. So he was asked about a conversation that he had with you. He says, we always talk about mutual cases.
Yes, absolutely.
He said that you had said to him, I've seen what you said about this and I think you're wrong. So I said, yes.
Somewhat blunt,
why?
yes.
So I said, yes.
Perhaps I should reflect on that.
From the way you have written the report, actually, I can tell you this is, and I'm trying to remember what Nat actually said, there was an awful lot more restraint than you have given credence to. It was words to that effect, which made me think. And he says that he then reflected on that and did think about the restraint and the extent of the restraint. Do you remember that conversation?
I do vaguely, yes.
Can you tell us any more about it?
I mean, I don't doubt his recollection of it, actually. That sounds about right, because I was pretty surprised at the time he gave that opinion. This was suddenly, everything's explained by sickle cell trait, which rides roughshod over the concept of restraint being potentially dangerous. So I don't doubt his recollection of that. What I'm pleased to say is that for this inquiry, he's obviously moderated a bit, and I would agree with him that it might well be appropriate to put it under part 2 of the cause of death. It may well be a factor, but not the main factor.
And again, does this come back to your approach as a forensic pathologist to consider all of the circumstances?
Yes.
Rather than simply just the scientific elements?
Yeah, very much so. I mean, circumstantial evidence is often crucial for forensic causes of death. And after all, from time to time, we all have to give evidence in court about cases where there's no body found or the body's so decomposed. So in those sort of cases, the circumstantial evidence is vital.
As I understand Dr. Shearer's evidence, she considers that an appropriate finding in relation to sickle cell would be that it go into part 2 of the certificate.
That. Yeah.
And so would you agree with Dr. Shearer on that?
I would.
And Professor Lucas also gave evidence that the quantity of sickling here tells me that this is much more than just post-mortem sickling. It happened peri-mortem as part of the death processes. And yesterday in evidence he explained that sickling occurred ante-mortem in life. He was asked about when sickling was likely to commence, and he said he was sure it developed a bit during the struggle and restraint.
Yes, and I'd support that.
You'd support that. I'd like to, if I may, go through with you the circumstances that we've heard evidence about in this inquiry and identify areas where there may be hypoxia, perhaps caused by, different causes, and what they may be. If we look first of all at sort of consumption of substances, we've heard evidence, and we've touched briefly on the nandrolone, the steroids.
Yes.
That had been taken, and we talked earlier about Dr. Shearer's evidence about recent administration. Dr. Shearer gave evidence that there was no evidence of any heart disease and took the view that nandrolone was unlikely to have played a role in the death. You agree with that? And I think we talked about Professor Edelson also expressing that view.
Yes.
You agree with it?
So you get it from a toxicologist's primary angle, but also 2 forensic pathologists.
Yes. And we've also heard some evidence from Professor Fremont, the osteoarticular pathologist, about the possible implications of steroids. But I think earlier you said you'd defer to him in relation to the bone issues and the fracture.
I do.
Thank you. In relation to MDMA, we've spoken about this, and I think, again, you said you'd defer to Edelson on toxicology and Professor Lipsage as a consultant psychiatrist.
Yes, I do.
On the impact of those. Alpha PVP.
I mean, the difficulty is, and I hope it hasn't happened yet, but it's when they then say they defer to the forensic pathologists and it all goes round in a circle. Everyone defers to everyone else. But
they're not deferring to you on that.
That's good. I'm pleased to hear that.
That's good. With Alpha PVP, I'd like to ask you about some other information that's available to the inquiry.
Yes.
We've obviously heard from Edelson and Lipsage about these matters, but I think as part of your inquiry statement, you were asked to consider Professor Crane's views. We could maybe look at your inquiry statement, paragraph 174, if we could. and this is Professor Crane, we've mentioned earlier. I acknowledge that in this context, Professor Crane is discussing excited delirium in the context of Mr. Byles' behaviour, as opposed to suggesting that it led to Mr. Byles' death. I think that is entirely fair. There's no doubt that people who have taken stimulant drugs may experience all sorts of bizarre behaviours. As a primary cause of death, I am of the opinion that unless the drugs are actually directly affecting the heart, which some drugs like cocaine can, they didn't have a primary role in causing death. I'm interested in that idea, the idea that these drugs could maybe just cause you to die suddenly, just out of the blue.
Yes, they can. I mean, it's particularly associated with cocaine. I'm not sure about alpha PVP, but I suspect anything cocaine can do, it can do. And if you go to A&E units, maybe here in Edinburgh as well as in London, you will find people who've taken cocaine who get chest pain and they get feverish because that's entirely a bad effect of the cocaine on their metabolism and on their heart, and they can get heart rhythm disturbances. So there are potential roles there.
And in this case, what makes you conclude that the drugs did not simply directly affect his heart and cause a sudden death?
Timing, so you can't ignore the fact he's been restrained and struggling at the time, but also he probably had the drugs a significant amount of time before, so you'd expect the maximum effect of the drugs to be at the sort of time after he took them, whatever time that was for the particular drugs concerned, and however he took them. So he might still have them as a background effect on his heart and other organs, but not as a sort of primary effect. Also, we would normally associate death due to drugs with overdose rather than just a normal abuse type dose.
And in terms of what you've said previously today, would that also mean ignoring any other factors like the restraint?
It would.
Which is not the
And you have to
approach
remember
I would
that,
recommend.
sadly, cocaine and other stimulant drugs are abused on a grand scale every weekend. And obviously we don't see many deaths directly due to them. And that is part of the epidemiology in the background to all this. You may get complications, but they're quite rare.
Right. Thank you. In terms of consumption of alcohol, we've already discussed that today.
Yeah, thank you.
I'd like to talk about evidence we've heard about an altercation that Mr. Byles had with his friend.
Yes.
A fight, to use an easier word. The chair has evidence available to him by way of a written statement from a Mr. Saheed, and he's also heard oral evidence from a neighbour of Mr. Byles called Naomi Rhodes. And this was a while ago, it was last year. But essentially, if I may, I'd like to read out a description.
Thank you.
And I'd like to get your comments on this. So in terms of the written statement, the description available to the chair is that in Mr. Byles' home, that he, as Mr. Saeed puts, sucker punched me from behind. He punched me on the head. He started charging towards me. I seen him starting running towards me. He picked up the washing line pole. He literally chased me all the way round the back of the house with the washing line pole, a wooden one. He threw the washing line pole, but it missed me. He pushed me onto the floor in a neighbour's garden. I fell over a wall. He was on top of me. He was throwing punches into my head. I tried to protect my head. He did throw a good few punches. So that's the description of the person who was involved.
Yes.
And then Naomi Rhodes, who heard a noise and viewed it. She's the neighbour. It occurred approximately between 6:30 and 6:45. She heard them. She saw Mr. Byles delivering 5 to 6 punches to Mr. Saeed. The altercation lasted approximately 2 minutes, from what she saw. So from that description, I'm interested in your views about whether that would place increased demands on the body for oxygen.
I mean, it'd be physical exertion with punching, but in a way it's evidence of how irrational his mental state was, really, which of course we know is primarily driven by drugs.
And
But I don't think it has any bearing on his immediate cause of death.
could that description be the sort of exertion that it runs the risk of developing hypoxia?
No, not really. It'd have to go a lot more than that. I mean, again, you know, I'm afraid with the abuse of stimulant drugs on a grand scale, these sort of altercations happen very frequently.
So, from that description, is there anything that I've read out to you that would give you any cause for concern it could lead to asphyxia in any
No,
way?
I mean, it does show his behaviour. It illustrates that. But we know that from the PM post-mortem examination, we don't have evidence of significant head impact either in the scalp or in the skull or in the detailed analysis of the brain. So it was with no consequences.
And we heard evidence from Professor Lucas yesterday that this, as described, would not be likely to cause sickling. Would you agree with that?
Yeah, I mean, he'd be the better person on that, but I agree with him. Basically, if it doesn't cause hypoxia, then it doesn't cause sickling.
Thank you. And if we've talked earlier about things that can cause a detrimental impact on a person's respiratory system. Even if there was any detrimental impact at all, would it be reversible at that stage?
Yes, it would.
So we've heard evidence from Neil Morgan, who's also a neighbour of Mr. Mayo, who talks about, shortly after this altercation, having a conversation with Mr. Mayo, where he's standing, engaged in conversation. Is that the type of behaviour that could allow that process to reverse, even if it had been created in the first place?
I mean, it's slightly what if. I find difficulty with that question. I mean, all I can say is I was aware of what had happened before, and I don't think that has any bearing on what happened subsequently, other than illustrating how his mind was altered.
Thank you. Then we've heard other evidence about Mr. Mayo's behaviour, where witnesses have seen him walking. It's a period of around, or I think just under a mile, around a mile, from his home address to Hayfield Road.
Yes.
And Professor Lipsage gave evidence that he retrospectively diagnosed psychostimulant intoxication at that stage.
Yes. And I would defer to him on that.
Yes. And so if I can again just read some descriptions of evidence that we've heard, that Mr. Mayo was chasing a complainer's car. So the person who had phoned up to complain to the police, chasing a car, jumping in front of other cars and stopping them. He was walking along the street. He was chasing cars, causing them to stop in the street, striking cars with a knife, perhaps hitting or kicking at a car. And in terms of that sort of level of exertion, any risk of causing hypoxia?
No risk of causing hypoxia, but it does illustrate how he was, and it's probably his elevated level of arousal and the catecholamines, the adrenaline, noradrenaline, dopamine, all those substances in his body elevated as part and parcel of that.
Right. And any risk from that description I've given you, or many descriptions, of any type of asphyxia?
No, not in my opinion.
And again, we heard from Professor Lucas yesterday that it would not be likely to cause sickling, but you'd defer to him on
I
that.
defer to him, but if it's not likely to cause sickling, it's not likely to cause anything else either.
Right. And again, even if there was any risk of any sort in relation to hypoxia, would it still be reversible at that stage? I'd like to move on to ask you about some evidence that we've heard about when the officers arrive at the scene in
Yes,
Hayfield
of course.
Road. The description of his walking at around that time is walking briskly, walking with purpose, eyes bulging out of his head, being high on something. And the first officer arriving, first two officers arriving, coming out of the first police van, which has arrived. It's a large police van. They're in full uniform. They have equipment with them. And they shout commands. They draw their sprays. And during that process, attempts are made to discharge a CS and PAVA spray
Yes.
at Mr. Bio.
And the problem is, in this mind-altered state, people often don't obey commands in any case. So it's a difficult problem.
We've heard evidence from Dr. Lipsage on that.
Good.
So in relation to that, particularly shouting commands and spraying with CS and PAVA, we have your evidence about the sort of chemical element of that. Is there a risk at that stage of hypoxia?
No.
And so
The difficulty is it's done quite commonly in these sort of circumstances. It often has no effect in terms of being a chemical incapacity to the person at all. And what it does mean is that then subsequent dealing with him means he's all contaminated by things that affect other people. So it's ill-advised, really. And I think the forensic medical examiners, the forensic physicians have made some quite useful recommendations on this. People tend to be resistant to those sort of sprays when they're in an excited state. And not only that, they don't do any good either.
we've heard some other evidence about sprays and
Yes.
these things. And so given the evidence you've just given, if no hypoxia, then no asphyxia, and Professor Lucas said no sickling.
Exactly.
You'd agree with that?
I do agree with that.
And then we've heard about a further attempt at spraying.
Yes.
That is presumably your evidence on that be the same.
Yes, it would.
Yeah. We then heard evidence about Mr. Bio possibly chasing another female police officer for a short distance.
Yes.
And striking her to the back of the head. And I'm interested in relation to whether that strike to the back of the head was of sufficient force to cause her to fall forward onto the ground.
Sure.
Is that the type of event or exercise that could cause a risk of hypoxia?
No. It's evidence of excessive exertion. But I don't know how fit Mr. Bayer was. And so it would very much depend on your fitness what any risk of exertion would have. But there wouldn't be a risk of hypoxia in anyone.
Not the risk of exertion that would overwhelm him physiologically.
No, exactly.
Professor Lucas certainly said no likelihood of sickling at that, and,
No.
and from what you said earlier, no risk of asphyxia.
Exactly.
And again, would that be reversible at that stage?
Yes.
Then there's the chair's heard evidence that's disputed about having struck the female officer and her having fallen, that he may have then used full body force to allegedly stamp. And there's different evidence about that the chair will have to consider. But again, would someone stamping with their full body force onto a person on the ground cause a risk of hypoxia?
Not in him, no.
It's him I'm interested in.
Yes. So it, what that means is he's just, to me, it shows he's capable of a lot of physical activity. But
not
I'm
to
not
the-
touching on the factual
Yeah.
basis for it in any case.
No, but that sort of level of activity wouldn't render someone at risk of hypoxia.
No, on the contrary, it shows that actually he's still functioning rather well.
We've then heard evidence from officers about an officer striking Mr. Bile with a baton
Yes.
on multiple occasions on his head and his body. And I wonder whether being struck by a baton with considerable force on multiple occasions would put you at risk of developing hypoxia.
Only if you're rendered unconscious by the strike.
There's no evidence to suggest that.
No. So I wouldn't expect a delayed effect of such a head injury. And of course, the hair can be quite cushioning against the effects of a strike. The neck may move on the body, and so may diminish the effectiveness of the strike in terms of force applied to the actual head.
Right. We've heard from Dr. Shearer about injuries, external and internal, in relation to that.
Yes.
And the chair has that evidence in front
Yes.
of him.
Yeah, good. I mean, I think there was one main injury to the scalp,
Thank you.
which might be the result of that.
But nothing that you're aware of from looking at the post-mortem or any of the results that would indicate there was a risk of hypoxia from the baton strike?
No, if the evidence is that he wasn't rendered unconscious at the time, then yes.
Thank you. And then there's evidence before the chair that Mr. Bile was brought to the ground at that stage
Yes.
by another officer. And it's been described as either a shoulder charge or as a bear hug type manoeuvre.
Yes.
And this is an officer who was around 25 stone. And that was done in a very quick period of time. Is that the sort of thing of itself that could give rise to a risk of hypoxia?
It would depend how sustained it was. So if the chest was compressed through such a bear hug for more than a few seconds, then that might be relevant. It may also be relevant to the development of the first rib fracture.
We've heard evidence about that.
Good, okay.
Yes. And so in terms of asphyxia, if the person was held for a few seconds in that bear hug or in the shoulder charge, could that cause asphyxia?
No, I'd expect that to be recoverable. Very unlikely to cause anything other than loss of, being toppled over, really.
And then the chair has heard evidence. He's heard evidence that Mr. Bile was in a prone position.
Yes.
He's also heard evidence that he was supine. I'm interested in the position and whether that of itself could cause hypoxia.
No, so this has been some of the misunderstanding that's been in this whole area, really. Prone of itself is not dangerous. It's just that a prone position, you're actually quite vulnerable to people then overdoing restraint. And of course, you're vulnerable to the abdomen being forced into the ground as well with pressure from the back. So I wouldn't say that the prone position is fundamentally dangerous. It's just in combination with excessive restraint it's dangerous.
So
And
again,
you don't see cases of supine restraint. I suspect because it's much more difficult to get control of somebody when they're supine.
So again, is it important when the chair's considering all these factors to consider the evidence that he's heard about the circumstances?
Yes.
And we've then heard evidence about the actual restraint itself.
Yes.
The chair has evidence about the number of officers who were involved and what they were doing individually. But he's heard evidence about, at one point, Mr. Bile performing a push-up type manoeuvre, seeking to lift officers from him. And if you could just give me a moment, I'd like to read out a description of this. So he sorry. His arms and legs were flying, kicking. This is a PC good. His arms and legs were flying, kicking out and arms flailing, and he was trying to force himself up using his arms like a press-up movement.
Yeah, well, that tended to imply he was on his front then.
Yeah. Several officers were trying to restrain him by pushing him to the ground. And PC Walker was lying across the top of the man's back towards the upper half in an effort to stop him from forcing himself to his feet. This was effectively to assist in pushing him to the ground. And then another officer, Tomlinson, talked about Mr. Bio was able to take, he's described it in evidence as a bench press type position, but he then went on to explain it was a press up, and he demonstrated a press up type position, and lift himself from the ground whilst attempts were being made to restrain him by PC Walker and I. He then said it would be a press up type position.
Yes. Again, that tends to imply he's on his front then.
Yeah. And he said Mr. Bio was making continued efforts to break free from the restraint and using his strength to lift myself and PC Walker upwards from the ground. So that's the sort of descriptions that some of the descriptions we've heard about this bench press, this press up that Mr. Bio was apparently attempting during the restraint. And I'm interested in that element of the restraint and whether that puts a person at risk of hypoxia.
Yes, it does. And I think the other thing is that's a huge amount of effort. If you think about from your description, that's an enormous amount of effort to lift just not one person, but lifting more than one. And of course, getting your own body weight off the ground in a press-up type manoeuvre. So that's good evidence for why the struggling should be part of the cause of death.
Sorry.
It also, I mean, it's stating the obvious, but it shows that he was not in any way unconscious in cardiac or respiratory arrest at that point in time, as he simply wouldn't have been able to do that.
Right. So not unconscious, but at risk of hypoxia.
Risk of hypoxia.
I think, as I said earlier, Professor Lucas gave evidence yesterday that it was during this that he was sure that would be when sickling would start.
Yeah, I think he's right.
So you think at risk of hypoxia. Professor Lucas said risk of sickling starting.
Yeah, so of course the sickling is a reflection of the hypoxia developing.
Yeah. And I'm interested in asphyxia then. So we've talked about hypoxia and asphyxia and that sort of process with sickling starting. Can you help the chair understand the sort of mechanism that's going on at this stage?
Yeah, so lack of oxygen in small blood vessels, so capillaries perhaps, and smaller veins, those cells in there and that lack of oxygen, the red blood cells in there would then start to sickle because it's a lack of oxygen that causes them to sickle.
And so you're talking about the risk of hypoxia and the extreme exertion.
Yes.
Because of the struggling.
Yes.
In terms of the restraint element, what the police are doing, what are the risks at that stage from this effort being applied to restraint?
They're contributing to a huge amount to the use of energy, but there may well be some restriction of breathing through the amount of restraint to the trunk.
You talked earlier about mechanical asphyxiation.
Exactly, so that's what it is.
So the weight or pressure or force being applied to the trunk.
Yes.
That's what you mentioned. And then if sickling is starting at this stage in the process, what impact is that also having?
Well, that will be, it depends obviously where it is, but if it's in vital organs like the heart or the brain, it could be a precipitating factor for sudden death.
And when you're talking about a precipitating factor, could you explain that to the members of the public?
Yeah, of course. So that means it's an immediate factor that once you've been rendered hypoxic, sickling may be one of the mechanisms that makes that particularly dangerous. Obviously, the hypoxia itself is dangerous to the brain and the heart. And as I think I mentioned earlier, the sickling and the development of sickling, to me, is more a reflection of the fact that this man's been rendered hypoxic. It's a marker within his system to hypoxia.
So he's developed the hypoxia. that has triggered the sickling,
Yes,
and then that makes the situation worse.
exactly. Yeah,
And as this is happening, there's the element of the mechanical
yes.
asphyxiation that you've
And of course
described.
that continues up to the time he's collapsed.
And that also makes the situation worse.
Yeah, exactly.
Are there any other factors during that moment or that time that we've not discussed?
I don't think so. I mean, obviously the drugs in the background and the physical exertion and the potential for lactic acidosis, they're all relevant to that.
I
final
wondered
step,
about the
second
lactic
step.
acidosis,
Yeah.
or the lactic acid building up to acidosis. How is that factoring into this?
That
explanation?
affects the heart negatively, and I think other opinions have actually suggested that the lactic acidosis could also be relevant to precipitation of sickling.
And so the levels of exertion that the descriptions, for example, of the press-up type movement, that level of exertion, that level of struggling, is that the type of exertion that could trigger lactic acid to build up?
I think it's very likely, and I think it's already going on to an extent.
Thank you. At this point, when all of this is happening, is it reversible?
Yeah, providing he's not in cardiac arrest, it's reversible.
Sorry, I didn't.
Providing he's not in cardiac arrest. Obviously, the sickling would have taken further targeted therapy. But just stoppage of what's going on is probably the most important thing in stopping the whole thing in its tracks. But then he will be in need of oxygenation as well, and whatever the treatment is for an acute sickling crisis.
So if the element of mechanical asphyxiation had been removed, just stopped, what impact would that have thereafter if he's suffering from hypoxia?
Well,
and
it would stop it getting any worse, but also assuming that advanced paramedics then attended and that he was assessed, they might not have been aware of the fact he was sickle cell trait positive, but that you hope would have been discovered by the time he transferred to hospital. And of course he'd been in a much better state to be transferred to hospital, even if he's unconscious, but still with a cardiac output and breathing.
We've heard other evidence in this inquiry about the benefits of calling for an ambulance.
Absolutely.
To have medical assistance available, preferably prior to any sort of restraint, or certainly at a very early stage. Is that something that
I think that's right. And actually, I think I mentioned before, I regard these cases as acute medical emergencies, and so you need to have something on standby for that. And I think the forensic examiners, actually, they're part of the Royal College of Physicians, and they've made a position statement, I think that may be before the inquiry, about the emergency nature of this sort of behaviour. So it's not just irrational behaviour or behaving badly or drug intoxication. They actually constitute emergencies, and sometimes they're dealt with very effectively in the A&E department.
We've heard some evidence that really an ambulance should be called if a restraint is being contemplated effectively.
In these circumstances, I think that's right, but obviously I'm not a physician, so that would be sensible.
You defer to physicians on that matter?
I would really. I mean, the trouble is there are only so many ambulances around, as we know, and but that sounds like it's quite an unusual situation that he presented with, so there is a risk of death.
I'd like to go back to something we spoke about earlier, but perhaps you would prefer a break. I can see you're maybe bothered by the lighting, are you?
No, I just get I get hay fever, so at the moment
dear.
that's quite bad at the moment. So
Oh, dear.
my eyes are just watering. It's not the stress of the whole thing. Though.
Would this be a convenient point to stop for lunch then? We'll stop at lunch and sit at 2 o'clock.